Okay, good afternoon. This is my fourth time to present at this podium. It's always a thrill, pleasure to come and see so many friends, meet new people. I especially appreciate the invitation from Dr. Coulter to come again and give an update. The last time I was here was 2018, and we've made a lot of progress even since then. And I'm going to extend that prior presentation today. And I want to give a very broad strokes overview as why, as a cardiologist, I'm interested in diabetes and kind of give you some of the history of how I got to where we are today. Everything I'll talk about today is type 2 diabetes. Nothing is related to type 1 diabetes. And it's very clear throughout the presentation, I am a cardiologist and not an endocrinologist. I think I may have one slide that mentions A1C. So we're going to be talking about the cardiovascular effects of some of these novel medications and how they've influenced clinical care just in the last 15 or so years. So here are my disclosures, and initially at first glance, I'm sure this is off-putting to at least some of you. I will give you the history of this slide as I went to Duke to train with Rob Califf, who's now the FDA commissioner. And Rob spent his entire career working with industry, doing industry-sponsored registration research. These are large-scale, randomized international outcomes trials sponsored by drug companies exploring novel therapies. And so I've had the privilege being in Rob's orbit to get connected at a very early point in my career, both with the International Trials Network, but also with drug company leadership and with other thought leaders around the world. So as we just began doing large-scale outcomes trials in diabetes, I got the seat at a table much earlier than I really even deserved, simply because I was connected and I had a focus on diabetes when very few people from a cardiology perspective did. And so with that, on the left are all of the companies with whom I've worked as leadership roles in the trials I'll be presenting today. Almost every trial that I will present today, I had some role at some level in the trial conduct. On the right are companies I continue to consult with as we develop new trials, new ideas, either testing new indications for existing therapies or novel therapies as we move forward in the cardiometabolic space, diabetes, but also in lipids and obesity. So I'm going to go back to my residency at UT Southwestern. When I was a resident in 1993, I came to Dallas. And at that time, we only had insulin or sulfonylureas as the therapeutic options for type 2 diabetes, two classes of medications, and that was it. And in 1997, we got metformin approved. So now we have a third agent. But I'll tell you, none of these had undergone any kind of cardiovascular risk evaluation, not only for efficacy, but not even for safety. Drugs were coming to market effectively untested in humans because of the unmet clinical need. And I'll point your attention to the drug here, tolbutamide, one of the very first sulfonylureas. And we learned a lot about tolbutamide from an early trial. So I got interested in diabetes because I picked a topic for an annual residence conference called ischemic preconditioning. And when I picked this topic to do a residence conference, I thought I would be talking about how ischemia induced angiogenesis and collateral blood flow and neovascularization. But what I quickly learned was this had nothing to do with blood flow. The ischemic preconditioning, the protective mechanism of iterative bouts of ischemia that renders a subsequent myocardial infarction much smaller in size, was mediated through an ATP-dependent potassium channel. And that potassium channel is the target of mechanism of action of the sulfonylureas. The sulfonylureas inhibit this channel. In the pancreatic beta cell, inhibition of this channel induces release of insulin. But in the heart, it could theoretically inhibit preconditioning, this teleologically protective effect. And so you begin to wonder, do we even know, are people dying because they're on sulfonylureas? We had no idea, except for one trial. This was one of the very first ever in any domain, large-scale randomized clinical outcomes trials. This was in type 2 diabetes patients at a number of centers in the United States that randomized patients with type 2 diabetes in the 60s. So this is way back in the old days, right? In 1960s or so, randomized them to the sulfonylurea tolbutamide, what's called insulin variable dosing, which is insulin titrated to tight glycemic control. An insulin standard arm. This was effectively an insulin placebo, 10 units of regular insulin once daily. And then they actually could, in the 1960s, treat type 2 diabetes with a placebo. And so this was a placebo-controlled 3 active arm comparator trial. And as you can see on the left, all-cause mortality, and in the right, total cardiovascular deaths. Look at the yellow line that takes off above all others. This is tolbutamide. And this is a statistically significant increased all-cause mortality and a statistically significant cardiovascular mortality with sulfonylurea. So this actually supports the notion that maybe these drugs are toxic. And it's because it was the only drug on the market, instead of removing it from the market, the FDA did the very unusual thing and just put in a product label a warning, effectively saying this drug might kill you. Now, as off-putting as that is, that's in every single product label to this day of every sulfonylurea in the United States. Oral hypoglycemics have been associated with increased cardiovascular mortality. We have not undone this signal despite 30, 40, 50 years after the original signal of safety concern. So I embarked on a career realizing we have a complete absence, a dearth of data in the emerging nexus of diabetes and cardiovascular disease. As I went through training, nobody ever taught me about cardiovascular risk associated with diabetes. We learned about eye disease, kidney disease, nerve disease, and the importance of glycemic control to mitigate microvascular disease risk. We never talked about atherosclerotic cardiovascular disease or heart failure or atrial fibrillation for that matter as risks of diabetes. So what happened? So there was a regulatory paradigm change. Most of you probably are aware of this. In 2008, both the FDA and in Europe, the European Medicines Agency simultaneously changed the rules for drug companies to develop drugs for diabetes. A lot of things led to that regulatory change that culminated in 2008. And I'll walk through some of those issues. But the reality is this was the perfect storm of a lot of things happening, leading us to the imperative to actually know for certain the safety, if not the efficacy, at least the safety of these compounds. And I liken type 2 diabetes, the treatment of type 2 diabetes, as kind of 2 different domains. One is glucose control for microvascular disease risk reduction. That's fairly evidence-based. And don't leave this room saying that McGuire doesn't believe in controlling blood glucose. But I liken it to cancer, to chemotherapies or cancer therapeutics. As we're treating the cancer, we always want to be certain we're not harming the cardiovascular system. And we have lots of cases where that's actually the case, where the cancer chemotherapy adversely affects some cardiovascular risk. It's okay, it's sometimes worth the risk to have the benefit of the cancer therapies, but we need to quantitate that risk, know how to survey for it, and ideally know how to treat it. So as we're treating microvascular disease risk, we best need to know at the very least we're not unfavorably affecting cardiovascular disease. And so it underpins what I'm going to walk through now. So when I was a resident, the population prevalence of diabetes, type 2 diabetes in the US was somewhere around 2%. And as time went on, around 2008, it was approaching 10% prevalence. So a very morbid and mortal disease affecting 10% of the adult population. We really must know how best to treat this, at least that the drugs we're using are safe. So the increasing prevalence of type 2 diabetes. And here, 2008 is roughly in the middle of this slide. And what you can see is it continues on to increase. And by 2020, we had exceeded 10% of the US adult population of having type 2 diabetes. And if you add to that the 3%, pretty constant 3% of people with type 2 diabetes who are undiagnosed, we're now at about 13% of the US population have type 2 diabetes. And again, this epidemic of a very serious disease begs robust data. Also, there's a growing awareness of the cardiovascular impact of type 2 diabetes. From the time I left UT Southwestern and went to Duke to do my cardiology fellowship, there began to be ripples in the literature about this cardiovascular risk. I contributed to some of that, but there were lots of people around the world banging this drum that we really have to pay attention to this cardiovascular risk. And this continues to grow to this day as we further and further embed the care of these patients into routine cardiovascular care, not necessarily treating hyperglycemia, but treating the patient and the risk that type 2 diabetes carries with it. So here are some data from the Swedish National Diabetes Registry, and I had the privilege of collaborating on this analysis where they have a population-based registry of every single patient in Sweden with diabetes, and these are the patients with type 2 diabetes, and they're represented in the blue are the people with type 2 diabetes, and in the red are 5-to-1 matched controls matched on age, sex, and county of residence. So we have 500,000 patients in the blue in the type 2 diabetes population, 500,000 people to analyze, and we have 2.5 million people in the red bars. So we have a study cohort of about 3 million patients here over about a 12-year period of time. And what you can see on the left is from the very beginning for myocardial infarction, those in the blue compared with those in the red have more than almost a twofold increased risk for myocardial infarction. Both of the groups declined over the study follow-up period, so that by the end of the study follow-up, it was just over 50 cases per 1,000 patient years. But you see what's happening in the blue lines is we're converging the risk. And so not only are they declining, they're declining faster than the patients without diabetes. So we are making progress. And by the time we reach 2013, if we do multivariable statistical adjustment, adjusting for all of the things that track with diabetes like obesity and hypertension and dyslipidemia, we can completely eradicate the incremental risk of diabetes per se. So in the statistical analysis that's multivariably adjusted, diabetes is no longer significant risk for myocardial infarction. Death is not the case. We haven't whittled away any of the risk of death. The relative risk between these two curves are not changing. They're both declining in time. We're doing better overall in cardiovascular care, but we're not whittling away that incremental risk. And so again, this is 2013. This is before we had the very first clinical outcomes evidence for any drug in the diabetes space to favorably affect cardiovascular outcomes. So this leads us up right to the culmination of some of the clinical trials that began in 2008, began to report around 2013, 2014. Also, we had the lack of proven cardiovascular safety or efficacy, as I've already mentioned, for more versus less glucose control. In fact, we have a number of large-scale randomized trials that randomize patients to more intensive versus less intensive glucose control with primary outcomes of cardiovascular events. As you can see on the top mortality, if you look at the advanced trial, ACCORD trial, the VADT trial, all of these randomized patients to roughly an A1C of 6 or 6.5 versus 7 or 7.5. So contemporary therapy versus more intense than contemporary therapy. And as you can see, there's no statistical significance in the meta-analysis, a point estimate, if you look at all the data together, of 1.01. So it's safe, but it's not incrementally beneficial. And I'll call your attention to the ACCORD trial where there was a statistically significant increased risk for mortality by intensifying glucose control. And so in patients at high risk, as they were enriched for cardiovascular risk, because these are cardiovascular outcomes trials, for patients at high risk, there is a penalty to pay in some cases for more versus contemporary glucose control. Now, again, this is not testing glucose control versus nothing. This is testing current standard of care, which is an A1C of 7 or 7.5. And so this is not throwing out glucose control altogether. It's just telling us moving farther doesn't really gain you anything. Stroke is the same thing, 1.02. And if anything, there's a statistically significant, relatively modest, but statistically significant reduction in myocardial infarction, so a 14% reduction. So no effect on mortality, no effect on stroke, and a slight benefit on overall on myocardial infarction. One of the most compelling reasons that we could change the rules is the proliferation of medications that had occurred up until 2008. And as I mentioned, in 1995, we only had 2 classes. 1997, metformin was approved. This is a slide that shows on the vertical axis the number of classes of drugs approved for an indication. In the blue are antihypertensive medications, and in the red are antihyperglycemic medications. And as you can see, about once every 5 years, roughly, in a pretty linear fashion, we added another class for treatment of blood pressure. Look at this long desert here. From 1950 up until 1995, we only had 2 classes of medications. This blip here, for about 17 years, we had fenformin on the market, treating patients with an early biguanide, but it was taken off the market because of lactic acidosis and lactic acidemia. So only in 1995 did we begin to add therapies. But since 1995, on average, we've added a new class of medication. And in many cases, these classes have 4 or 5 or 6 members. We've added on average 1 class every 2 years. So from a cardiology perspective, if you're not engaged in the diabetes literature, this seems to be overwhelming. How do we tell one from another? I'll point your attention to just a few things. One is I will focus almost the rest of the presentation on GLP-1 receptor agonist, and at the very top here, SGLT2 inhibitors. But how many in the room realize that cholesevolin, a bile acid sequestrant, approved initially for LDL control. Cholecalciferol is indicated for the treatment of hyperglycemia and type 2 diabetes. Does anyone in the room know about that? So this was a post-marketing observation of patients treated with cholecalciferol for LDL cholesterol actually had less incident diabetes, and those with diabetes had better glucose control. Bromocriptine, that's used for hyperprolactinemia, is also observed serendipitously to lower blood glucose. The mechanism is not well understood, but the data are supportive of a product label. So bromocriptine, never used as far as I know, but does have an FDA indication. So we'll go from there. And then lastly, the straw that broke the camel's back was the accumulation of one after another post-marketing observations of adverse effects on cardiovascular outcomes of one drug after another. Some drugs cause hypoglycemia and increased risk. Some drugs cause weight gain and increased risk. Some drugs cause heart failure and amputation. So this is what most people believe is the reason the FDA changed their strategy, requiring every drug company for every compound moving forward to demonstrate at a minimum cardiovascular safety. So these are the data from the thiazolidine dione medications, rosiglitazone on the left and pioglitazone on the right. And as you can see with rosiglitazone, this is a point estimate of risk for myocardial infarction. Every single point estimate in every single trial is to the right of unity, suggesting a signal of harm, right? It is increasing risk. Not any individual trial is statistically significant. But if you do a meta-analysis, as Steve Nissen did and published in about 2006, if you do a meta-analysis of the existing data using trial-level meta-analysis, not patient level, you get an increased risk, statistically significant 43% increased risk of myocardial infarction. A subsequent independent analysis demonstrated exactly the same finding. So two replicated findings of two different groups doing meta-analysis. And most compelling, GlaxoSmithKline, the maker of rosiglitazone, did an internal patient-level meta-analysis, the gold standard of meta-analysis, and published a 31% increased risk. So initially, the product label was modified to suggest this increased risk, and ultimately, effectively, rosiglitazone is not being used anywhere in the world. The opposite is true with pioglitazone, that one single outcomes trial, the proactive trial, just missed statistical significance, and a meta-analysis also suggests, but not reaching statistical significance, if anything, a clinical benefit. But at the very least, you could say pioglitazone has demonstrated cardiovascular safety. Now, there are other issues with pioglitazone, including weight gain and risk for heart failure that has precluded its common use. So here's the announcement in December of 2008, where the FDA changed the rules. Every drug company has to demonstrate a minimum of cardiovascular safety. What this means is we now have to do cardiovascular outcomes trials. Up until this guidance, you could bring a drug to the US market for the treatment of hyperglycemia with as little as 250 patient years of data. So all you had to do is study 200 patients for 6 months, and you only had to study 100 patients for a year. This is a lifetime disease, and how are we bringing drugs to market? Effectively not even studying them in humans. So these are not even pilot trials that are bringing drug after drug to market. So this amplifies the requirement. This increases the resource requirement to bring a drug to market 70-fold, 70. So now drug companies that have been getting drugs relatively cheaply to market now actually are going to have to pay a lot of money to get their drugs approved. And of course, everybody cried foul that the sky is falling. We can't afford to do this. We can't find all these patients, but we all know that's not true now, 14 years later, as we have an avalanche of data from the outcomes trials. So I'll just summarize by class in 30,000-foot level what we've observed from these new classes of medications. So the DPP-4 inhibitors, these are once daily tablet medications. They inhibit the endogenous degradation of GLP-1. So these potentiate endogenous incretin action. Think about this like sacubitril inhibiting BNP degradation. So this is the same concept. We're inhibiting a protease and enhancing the endogenous activity. So there were 4 of these drugs approved and are still approved on the US market. One of the benefits is these induce glucose-appropriate insulin secretion, and so there's no hypoglycemia risk, and they also have a neutral effect or maybe a slightly beneficial effect on weight. And so we've taken 2 of the key limitations of sulfonylureas, hypoglycemia and weight gain, and eradicated them with these drugs. And so these were very rapidly taking up in the endocrinology community, not so much in the cardiology community. So here's a summary of the total class. Each one of these drugs underwent a dedicated cardiovascular outcomes trial, and these are ordered top to bottom in order of their presentation and publication. So first was the SAVOR-TIMI 53 trial. We're now doing 15,000 patient randomized trials, the SAVOR-TIMI 53 trial, 15,000 patients with type 2 diabetes with or at high risk for ASCVD. And by the end of the trial, after 15,000 patients and 3 years of median follow-up, 45,000 patient years of observation, we proved the point estimate that we ended with was exactly what we started with, 1.0, completely null effect. Absolutely no suggestion of cardiovascular benefit. So that's the glass half empty interpretation of the SAVOR trial. But I will remind you that all of these trials I'll be presenting primarily were designed to prove safety. So non-inferiority testing was the primary outcome. And in here, the non-inferiority margin designated by the FDA is 1.3. So as long as that upper confidence limit is less than 1.3, you can claim safety. So saxagliptin is proven safe, but not incrementally beneficial. Then we saw the same thing over with alogliptin and over with sitagliptin and over with linagliptin, exactly the same results. So 4 drugs, 1 class, every single one of them showing safety, but not incremental efficacy. So this led the field to begin to cry foul. We've now spent about $500 million on these 4 trials, demonstrating absolutely no benefit, no advance in the field. We're not making things better. And so people started to cry foul. So when we presented the data at the ESC at a late-breaking trial, the heart failure analysis from the TECOS trial, the discussant to our presentation was Gabriel Steg, who's a good friend of mine. And I disagreed with every single thing he said at the podium. He pretty much said, we're wasting our money. We have to stop doing this. We have to figure out how to do something better. Of course, he didn't have any ideas about how to do it better, but he criticized the whole field. So one of my roles is I'm deputy editor of Circulation. So I get to commission content. And so I sent Gabriel a note. I said, I disagree with everything you said, but I'd like to publish it. And so he and his colleague in endocrinology in Paris wrote this criticism of the present state of randomized trials, and we published it in Circulation 2016. Effectively, simultaneously, this bottom one was published in Diabetes Care, and interestingly, the 3 authors on this paper criticizing the current state of affairs were 3 of the key consultants to the FDA that designed this strategy. So these 3 were all consultants to the FDA, Rob Smith, Allison Goldfein, and Will Hyatt. And despite the fact that this was their idea to begin with, they're now criticizing their own work. But let me remind you, the reason we do these large-scale randomized trials, we're now doing 15,000 patient years of observation as opposed to 250. The reason we do these trials, we're designing them as cardiovascular outcomes trials, but this gives us an opportunity in a randomized blinded setting to test all manner of adverse effects. And so as we're measuring and prospectively collecting and adjudicating the cardiovascular outcomes, we're also collecting all the liver events and all the kidney events and all the eye events and all the amputation events. And we have all this safety monitoring. And so these are 3 examples of trials. I was on the executive committee of each of these trials. Tirzepatide, this was the first once weekly GLP-1 receptor agonist. Roche Pharmaceuticals was the sponsor. After about 600 patient years in our cardiovascular outcomes trial that was designed for 15,000 patient years. After 600 patient years, we observed nausea. We know that GLP-1 receptor agonists cause nausea, no big deal. Some vomiting, we expected that. Antibody formation, 50%, 50% of patients exposed to Semaglutide developed antibodies to the compound. And some of them were neutralizing, but some of them were active, and we had anaphylactoid and anaphylaxis reactions, killed the compound. 600 patient years of observation, we would have not have seen this anaphylactoid reaction if we'd been doing the earlier days of 250 patient years of observation. Here's another trial, the ALI-CARDIO trial of aliglutide. This is a dual PPAR alpha gamma agonist, so it combines the effects of the thiazolidinediones with the effects of fibric acid derivatives. So it lowers glucose, lowers triglycerides, raises HDL. 14,000 patients, these are type 2 patients with type 2 diabetes, immediately post an acute coronary syndrome. We had 7,000 patients enrolled in our trial with a median 2 years of follow-up with the DMC says, stop the trial. We saw heart failure. We expected heart failure. It's a TZD. We expect to see heart failure. That's a manageable risk. Decline in EGFR, all the fibric acids will drop the EGFR. It goes back to baseline when you stop the drug. It's not kidney injury. Bone fracture, didn't expect it, but it was observed and it had been seen in a couple of other TZD trials. But what stopped the trial was GI bleeding. So how does a fibric acid TZD cause upper GI bleeding? But it did. The curves emerged or diverged very early, and they continued to separate. There was a 40% statistically significant increased risk for GI bleeding. We would have never expected GI bleeding to be the rate limiting step for this class of medications, but it killed the trial, killed the drug, killed the entire class. Nobody's developing dual agonists for PPAR alpha gamma any longer. Then the last one is Fasiglufen. This is a G-coupled protein receptor 40 agonist. So by agonizing G protein receptor 40, GPR40 in the liver, you reduce hepatic glucose output. And so inhibiting glucose output, lowering blood glucose. 2,000 patient years into our 10,000 patient year trial, we stopped the trial for a 10-fold excess risk of LFT abnormalities. This was hepatotoxic, killed the compound, stopped the trial, killed the class. Nobody's developing GPR40 agonist anymore. So we would have never seen these signals had we not been in the old days of clinical development. So I don't think we're wasting our money. I think it's important to have large-scale randomized evidence, no matter what you call the trial. You can call it a cardiovascular outcomes trial. You can call it a safety trial. You call it whatever you want. We need to survey systematically safety events. We learned that lesson in the SAVOR-TIMI 53 trial, where we observed a 27% statistically significant increased risk for heart failure with a DPP-4 inhibitor. Now, we believe that the DPP-4 inhibitors would favorably affect heart failure because, like sacubitril, they inhibit DPP-4 is one of the proteases that degrade B and P. So we expected these would have a secondary effect of potentially favorably affecting heart failure. We prospectively collected and centrally adjudicated the heart failure events. So these are bona fide heart failure events, just like in a cardiovascular outcomes trial. It was not part of the primary outcome. So it's to the credit of the companies. They actually spent the money to centrally adjudicate events that weren't even in the primary outcome. They would have no chance of submitting an FDA application for these outcomes. But because we so rigorously collected it, we were able to demonstrate, and we all believe on the team, that this is a real finding. Saxagliptin somehow is different than all the others. We have no idea the mechanism. But we also went back and dug into the preclinical and early clinical data. We can't find a signal anywhere in the data set to suggest that heart failure might be a problem. We only detected it because we did a 15,000 patient trial with a median follow-up of 3 years. Examine was the second trial reported allogliptin and post-acute coronary syndrome, an adverse safety signal of a 19% numeric increased risk. It was not statistically significant, but it looks more similar to than different from the saxagliptin observation. So as these data were being curated and published, I was on the executive committee of TECOS, and I chaired the CARMELINA trial. In both of these two ongoing trials, we prospectively planned a statistical analysis plan to analyze heart failure and filed it with the FDA. Unlike these previous two trials, this was found by exploratory analysis that weren't prospectively planned or specified. And so there's a little bit of uncertainty about their statistical legitimacy. The large numbers take most of that uncertainty away, but still they weren't prospectively planned. So we had prospective plans and a statistical analysis plan for sitagliptin, no effect whatsoever, not favorable, but not unfavorable either. And if anything, the linagliptin has a numeric improvement. We don't claim an improvement, but we can certainly, with great validity, claim safety. So there's no heart failure concern for these two members of the class. So that's the glass half empty part of the talk. Now we have lots of evidence favorably supporting the use of these two new classes, the SGLT2 inhibitors. There are 4 on the market. Each one is once a day. They inhibit glucose reclamation from the urine filtrate. So they increase urinary glucose excretion, and by creating a renal sump of glucose, basically they lower blood glucose. We thought this was a crazy idea early on. We'd be seeing UTIs left and right, and we thought this was nonsense, but data tell us otherwise. So there have been cardiovascular outcomes for each one of these trials. Represented here are 6 trials in 5 different domains. And so again, ordered top to bottom in the order they were presented. The EMPA-REG outcome, a statistically significant 14% reduction in cardiovascular death, MI, and stroke. This in 2015 was the very first trial in the history of diabetes research, type 1 or type 2, to have a clinical outcome benefit, right? All the type 1 data are based on photographs of retina and eGFR decline and albumin in the urine. There's no clinical outcome supporting type 1 diabetes glucose control, although we know it's necessary. It is insulin dependency. So this was the first clinical outcome trial to show superiority. It was fairly quickly replicated by 2 trials combined into one analysis in the CANVAS trials program. So this is the CANVAS and the CANVAS-R program of canagliflozin, exactly the same to the 1,000th decimal point, almost exactly the same findings. So this is proper replication of the results. Then in the DECLARE-TIMI 58 trial with dapagliflozin, there's no statistical difference. There's a favorable point estimate and an upper confidence limit less than 1.3. So at 1.03, we can claim safety, but we cannot claim incremental benefit. So there looks to be some difference, one drug to the other, one population to the other. Credence, this was a kidney impaired patient population tested for canagliflozin, a 20% relative risk reduction, achieving statistical significance. And then the last trial, Vertus CV, no difference whatsoever, point estimate almost 1.0. And so you can say that neither ertugliflozin nor dapagliflozin favorably affect atherosclerotic cardiovascular outcomes. Empagliflozin and canagliflozin do, and because of that, they have product labeled indications. And the product labeled indications are really important when you're negotiating third-party coverage for these drugs. Very different story for heart failure. As all of you know, these drugs have really penetrated the heart failure landscape, and it's because we observed all of these heart failure effects in every one of the trials of SGLT2 inhibitors, and it didn't matter the population nor the drug being tested. There's complete homogeneity of the parameter estimates here and a point estimate of a 32% class-wide benefit. So ertugliflozin, although doesn't improve atherosclerotic cardiovascular outcomes, it looks just like every other SGLT2 inhibitor when it comes to heart failure. And I'm not going to show the data, but the same is true for kidney outcomes. They all do the same thing in the class. And not only do these drugs reduce risk, they do it quickly. This is the heart failure cumulative incidence curves from each of the large trials: EMPA-REG outcome with empagliflozin, canagliflozin in the top right, dapagliflozin bottom left, and ertugliflozin bottom right. These curves look almost identical, and you look how quickly they begin to separate. Within the first few days, these separate. In fact, these trials all achieve statistical significance, except for DECLARE, the other three, within the first 30 days of the trial. And so every day you go without prescribing these drugs to this high-risk patient population, you're losing a day of opportunity of efficacy. And so this does beg a little bit of urgency to get the drugs on board for patients with an indication. And this is just a qualitative summary of the 4 trials I've just presented of the SGLT2 inhibitors. The green colored boxes are ones that are nominally statistically significant. Yellow are safe but not incrementally beneficial. So what you can see going to cardiovascular death, empagliflozin is the only one that has a statistical superiority. Both EMPA and CANA are statistical superior for atherosclerotic cardiovascular disease. All of them are the same for kidney and heart failure. So this changed our thinking. All of these data, I spent the first 15 years of my career talking only about atherosclerotic cardiovascular disease risk associated with diabetes. We have to give antiplatelets when they're indicated. We have to get the blood pressure well controlled, LDL in the sync. We want to tackle all of these ASCVD risks, so MI, stroke, and peripheral arterial disease. So these SGLT2 inhibitor data really make us refocus our attention, broaden our attention to the heart failure realm, and understand what we're doing that favorably is affecting heart failure. And there's lots of proposed mechanisms. I'll go into a few of them in qualitative summary in a minute, but we know that heart failure and kidney disease are dramatically interrelated with one another and also with ASCVD risk. And so now we have the trifecta of atherosclerotic cardiovascular disease, heart failure, and kidney outcomes for which these drugs all have product labeled indications. So what do SGLT2 inhibitors do? Well, they're diuretics. They reduce intraventricular volumes. They also lower blood pressure, both through the diuretic effect, but also through probably renin-angiotensin aldosterone system attenuation. They're sympathomimetics or sympatholytics. And so they reduce sympathetic nervous system activity, which lowers heart rate. And they increase circulating ketones. And so all 4 of these, each individually and in context, reduce myocardial oxygen demand. In addition, hemoglobin and hematocrit are increased through erythropoiesis. This is not concentration, hemoconcentration. This is actual expansion of red cell mass. So we're increasing oxygen delivery. And if you put all this together, this is kind of like an intra-aortic balloon pump in a pill, right? So we're optimizing myocardial oxygen demand and supply. And so again, as editor of Circulation, I get to invite my good friend, Professor McGuire, to write a paper and teach us about the ketones and their importance. These drugs all increase circulating ketones, especially in the fasting state. ketones are highly efficient metabolic substrates for the brain and for the heart. And so that is one potential mechanism of cardiovascular benefit. But a lot of other things have been demonstrated recently. There are direct myocardial effects. They're positively inotropic, thought to be mediated through the sodium hydrogen exchanger 1. They're antiarrhythmic. They affect a couple of electrolyte channels, potentially causing an antiarrhythmic phenomenon. More recent data suggests they induce nutrient deprivation signaling. And so it induces autophagy. And so there's cleaning up of the heart and the kidney potentially. And then also they reduce body mass by the glucose, the caloric loss with glucose, favorably affect albuminuria and stabilize eGFR. Now, the last is the summary of the GLP-1 receptor agonists. These mimic the endogenous incretin system. We have injectables at the top, liraglutide once daily, semaglutide once weekly, dulaglutide once weekly. All three of these have proven cardiovascular benefit and have FDA product labels independent of glucose control in patients with diabetes and atherosclerotic cardiovascular disease to be used for cardiovascular risk reduction. We have ongoing trials of oral semaglutide and subcutaneous tirzepatide. I'll talk about those at the end. We know that the GLP-1 receptor agonists reduce blood pressure. Here's just a meta-analysis of a smattering of trials showing about a 4% reduction in blood pressure. Some of this is due to the weight loss associated with these drugs, but not all of it. They directly and fairly acutely favorably affect blood pressure. Weight also, we know several of these drugs are now being developed specifically for the treatment of obesity independent of diabetes. An average of 3% weight loss. We know that we've seen even greater weight loss as we've modified the therapies. And here's a summary of the cardiovascular outcomes data. Just very quickly, I'll remind you that 0.86, that's the same thing we see with the SGLT2 inhibitors. So both of them modest, but both of them incrementally beneficial on the backdrop of very good evidence-based medicine, 14% relative risk reduction, and driven again by the trials I just showed you, liraglutide in the LEADER trial, semaglutide in SUSTAIN-6, and dulaglutide in the REWIND trial. These drugs do a lot of things in addition to lower blood glucose. The GLP-1 receptor agonists have been shown in many animal models to have a lot of pleiotropic cardiovascular effects, reducing infarct size in an animal model of myocardial infarction. They're anticoagulants. They inhibit platelet activation about the same as aspirin. They reduce postprandial lipid excursions. They reduce inflammation by mechanisms that remain not understood, possibly by reduction in fat cell mass. They decrease body weight by central action on the satiety center in the brain. And again, as I mentioned, they reduce blood pressure. So here's one caution is that we don't know the safety of these drugs in advanced heart failure. Patients with type 2 diabetes and advanced heart failure, there are some domains where there's a clinic for patients with advanced heart failure and obesity. So they're using these drugs to get the patient less obese to get listed for transplant. And that's a little bit of a worry for me because we have some data to suggest these may be adverse in the setting of advanced heart failure. Here's one low ejection fraction heart failure trial of liraglutide versus placebo. These are patients with or without diabetes. You see the curves separate unfavorably for liraglutide and continue to diverge to a point estimate of about a 30% increased risk for hospitalization for heart failure and death. Now, it's not statistically significant, but it's awfully close, and it goes exactly in the opposite direction. Another trial called the LIVE trial, almost identical in design, showed the same thing. And if you put them together, you can demonstrate statistical inferiority for liraglutide in low EF heart failure. So these drugs and all the data I've just shown you have now entered our guidelines. This is what I think is the best guideline in the cardiology domain. This is the European Society of Cardiology guidelines from 2020. So if you have a patient with type 2 diabetes who just got diagnosed, not on any drugs, the cardiologist would advocate going straight to the use, if you have ASCVD or high risk, straight to the use of an SGLT2 inhibitor and or a GLP-1 receptor agonist, independent of metformin use. So metformin is first line for low risk, brand new patients with diabetes. But if you have atherosclerotic cardiovascular disease, we think metformin should be left to a third line agent. These first two steps are independent of the need for additional glucose control. Then you can measure the glucose and see if you need to add something like metformin to that. If they're already on metformin, no big deal. Lots of patients in the trials were already on metformin, and these are additive benefits to metformin. And so the same recommendation to consider independent of glucose control. addition. The ADA finally caught up to the cardiologists in their 2022 update for the treatment of type 2 diabetes. You can see at the top, they recommend SGLT2 inhibitors and or GLP receptor agonists independent of A1C, so independent of glucose control requirement, independent of what you're targeting the glucose to, and importantly, for the first time, the diabetologists have acknowledged it doesn't matter if they're on metformin or not. And so they're getting away from their dogmatic approach to metformin first for everybody. So just as I mentioned, just like the ESC guidelines for patients with ASCVD or high risk, consider one. Then if the A1C is above target, consider the other one. I think we can skip this A1C above target step and just go straight to both of them. Now, that's an expensive proposition for sure, but the evidence supports it. If there's heart failure present, of course, SGLT2 inhibitors are preferred. And we've seen the data for SGLT2 inhibitors improving kidney outcomes. And so they're now level 1A indicated in the nephrology literature for kidney disease mitigation. So this is a clinical trials group that I'm working with based at the DCRI at Duke. We've just completed and we'll be reporting on Monday at the ACC the results from a cluster randomized trial of education for cardiologists versus not, and showing the incremental use of all evidence-based medicines, not just the SGLT2 inhibitors. But here's what we published in Circulation, a call to action. The cardiologists just have to get on board and adopt these therapies just like we adopted the statins. These are cardiovascular medicines, not diabetes medicines. Again, as Circulation Deputy Editor, I get to commission these articles. So I commissioned a primer. This is a 1,200 word, how does a cardiologist prescribe an SGLT2 inhibitor? And similarly, we published a GLP-1 receptor agonist primer. What do you think about? How do you start? How do you titrate? What adverse effects do you consider? So just a couple of minutes, I'll talk about the where we're going. So one, I mentioned already, the oral semaglutide formulation. This is semaglutide's proven effective with injectable once weekly formulation. Novo Nordisk has now developed a once daily oral semaglutide. It's on the market for glucose control. It doesn't yet have a cardiovascular claim because we have this trial ongoing. I'm the chair of this trial studying semaglutide versus placebo added to background antihyperglycemic therapy. We've enrolled over 10,000 patients, actually 9,600 patients. The trial has completed enrollment and it's now in its follow-up phase. We'll probably get these data in about a year. Then we'll switch to Tirzepatide. All the buzz, you're hearing about it in Hollywood and everybody wants Tirzepatide and they're having Mounjaro parties. Tirzepatide is a dual agonist of GLP-1 plus gastric inhibitory polypeptide. So two different incretins being agonized. This drug, we've never seen weight loss like this for any therapeutic except for bariatric surgery. On average, in the top dose of Tirzepatide, it's shown a 23% average weight loss. This is really remarkable and literally does replicate bariatric surgery. So now we have in a once weekly injection, the potency of bariatric surgery. Here's a meta-analysis we published on the totality of the data to date on Tirzepatide and a lot of phase 2, small phase 2 and early phase 3A trials. We only have a total of 142 atherosclerotic cardiovascular events to analyze. But as you can see, in every cardiovascular event that's analyzed, the point estimate is going in the favorable direction with numbers fairly comparable to what we know about the GLP-1 receptor agonist class. This is way too early to claim a victory. But again, as you can see, for the atherosclerotic, we've already achieved the FDA requirement of eliminating an upper confidence limit of 1.3. So pretty good data that these are safe. We're now conducting the SURPASS cardiovascular outcomes trial. I'm on the executive committee of this trial. We've enrolled just under 12,500 patients. Again, a huge trial enrolled during COVID, which is amazing. And we now have completed enrollment and in follow-up period. This is the first trial where we finally acknowledged with all of the evidence we have, we can no longer do placebo-controlled trials. And so this is a creative analysis strategy that I helped the company develop, and the FDA has now signed off on this. So for the first time in the history of diabetes, we're doing an active comparator non-inferiority trial. So if you think about how all the DOACs came to market, they all were tested against a proven comparator, right? Warfarin. And so now that we have proven comparators, we can do a non-inferiority trial against a proven comparator. And if we're successful there, we can then do what's called an imputed placebo analysis, where we analyze our outcomes with the tirzepatide group against the placebo-treated patients in all of the GLP-1 receptor agonist trials. And if that's successful, the FDA has conceded that they will give a claim of superiority against a placebo. So this is a really creative, different way to do analytics, and the FDA's the Center for Drug Evaluation and Research has never used this methodology except for cancer therapies and antibiotics. So I'll finish with that. We've really had dramatic altering of our clinical care in the space of type 2 diabetes with respect to cardiovascular disease. A lot of agents have demonstrated safety, but not incremental efficacy. I would leave these to the glucose management that's being done by the endocrinologist or the primary care physician. But for cardiologists, we now have cardiovascular benefit for these drugs. 3 members approved with labeled indication of the GLP-1 receptor agonist, and 3 drugs in the SGLT2 inhibitor class. These now have a 1A level indication, and third-party payers are almost all covering at least one of these at tier 1. And so in a routine clinical practice in cardiology, we need to be prescribing these. If a patient leaves your clinic without a prescription for one of these, it's just like letting them leave without a statin if they have atherosclerotic cardiovascular disease. So really do need to learn how to use these. And I'll just finish with that. I'll be happy to answer any questions if we have questions.